For this section of the endocrine system, we'll be talking about the pancreas. Let's look at the location first. It is found in the level L1 to L2 and it lies posterior to the stomach. It is known as a secondary retroperitoneal organ, meaning that it used to be suspended in the mesentery, but then later it migrated behind the peritoneum during development. So let's have a look at the structure of the pancreas. Here's the pancreas, and this part of the pancreas is known as the uncinate process. We have the head of the pancreas, we have the tail of the pancreas, and also the body. So what are the structures around the pancreas? So around the head of the pancreas, we have a C-shaped duodenal loop. This is the duodenum. And at the tail actually extends to the spleen. This is the spleen. And so let's have a look at the structures behind the pancreas. So we have the abdominal aorta behind the pancreas that gives off a branch called the superior mesenteric artery. This artery actually is anterior to the uncinate process, but posterior to the body. We have the inferior vena cava that I just drew, and it gives off the branch superior, not the branch, but the superior mesenteric vein is also anterior to the uncinate process, which drains into the inferior vena cava. We also have this artery that I just drew at the superior border of the pancreas, which is the splenic artery. And here I drew a green structure that is known as the bile duct. So let's look at the ducts of the pancreas. We have the pancreatic duct, which starts from the tail of the pancreas and runs along the body, and it joins with the bile duct to form the ampulla of Vater, or the hepatopancreatic ampulla. This then enters into the descending part of the duodenum, and it is called the major duodenal papilla. And for extra information, the ampulla is surrounded by the sphincter of Oddi. So this is the major duodenal papilla. We also have an accessory pancreatic duct, which empties into the duodenum above the major duodenal papilla, and it's called the minor duodenal papilla. So let's have a look at the microscopic anatomy of the pancreas. So what is interesting about the pancreas is that it has both an exocrine part and an endocrine part. We'll have a look at the exocrine part for a second. Here I'm drawing you the serous acinar cells, which secrete and release digestive juices and enzymes, and that gives the pancreas its exocrine function. So here's the serous acinar cells. And so that is all that we'll talk about for the exocrine part. Let's have a look at the endocrine part now. So the endocrine part is actually a cluster of cells called the islet of Langerhans. These cells are actually hormone-producing cells. And the main cells that we need to know are the alpha cells, which are in red, the beta cells, which are in pink, and the delta cells, which are in blue. So the alpha cells, they release hormone called glucagon, and the beta cells release the hormone called insulin, and the delta cells release somatostatin. So the alpha cells make up about 15 to 20% of the islets, beta cells about 70%, and delta cells 5 to 10%. So let's look at the function of insulin first. So insulin promotes the storage of absorbed nutrients in the form of glycogen or fat. And so it basically it promotes the glucose uptake into the liver, the skeletal muscles, and the adipocytes. Glycogen actually does the opposite of insulin. It actually mobilizes energy reserves, especially during starvation or in stressful situations, promoting glycogenolysis and gluconeogenesis. Stimulus for insulin is increased blood glucose level, and stimulus for glucagon is decreased. Somatostatin acts as a regulatory hormone, actually inhibiting the release of insulin and glucagon. Now let's look at the vasculature of the pancreas. So here I'm drawing the abdominal aorta, and abdominal aorta gives off three branches called the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. So let's look at the celiac trunk. The celiac trunk gives off three branches: the splenic artery, the left gastric artery, and the common hepatic artery. So the common hepatic artery, it has many branches, but the one that we will look at in particular is called the gastroduodenal artery, which supplies to the head of the pancreas. So it gives off the superior, posterior, and anterior pancreaticoduodenal artery. These anastomoses with the inferior, posterior, and anterior pancreaticoduodenal arteries, which are from the superior mesenteric artery. So this is all for the head of the pancreas. Now the splenic artery actually provides blood to the body and the tail of the pancreas. Gives off the inferior pancreatic artery, there's the dorsal pancreatic artery, and the great pancreatic artery. Now for the veins, here's the pancreas again, and from the body and the tail, the pancreatic veins actually drain into the splenic vein. The inferior mesenteric vein also drains into the splenic vein, and this will join with the superior mesenteric vein, which is where the pancreatic veins from the head will drain into. And together, the superior mesenteric vein and the splenic vein will drain into the hepatic portal vein. So for the nerve supply, the sympathetic fibers come from the celiac plexus, and the parasympathetic fibers from the vagus plexus. Now let's look at the clinical anatomy of the pancreas. So starting off, let's talk about the annular pancreas. For this, we need to know the embryology. So the pancreas is actually developed from the ventral and dorsal buds from the foregut. With the ventral bud, we have the bile duct. So during development, the foregut rotates, and this will also rotate the ventral bud, and it will join with the dorsal bud, and it will fuse together to form the pancreas. This is what happens normally. But if the ventral bud splits into two segments, then the two segments will rotate, and it might constrict the foregut, the duodenum, and this part of the duodenum may undergo atresia and may not be present at birth. Next, we have the acute pancreatitis, which is life-threatening, and it results due to the activation of the pancreatic enzymes within the pancreas itself, destroying the parenchyma. Cancer of the head of the pancreas can spread to the duodenum or cause obstruction of the bile duct, pancreatic duct, or hepatic duct, resulting in obstructive jaundice. Diseases of pancreas can also lead to backup of the hepatic portal vein or the inferior vena cava, leading to ascites and edema of the lower limbs. Let's look at the clinical relevance of the endocrine function now. Starting off with diabetes mellitus. Absence of insulin leads to hyperglycemia, resulting in diabetes mellitus. So hyperglycemia is regarded as glycemia above 120 milligrams per deciliter. There's two types. So type 1 diabetes is when the pancreas cannot produce enough insulin due to body's own T cells attacking the pancreas. So basically, it's an autoimmune attack on the beta cells. Type 2 is a decrease in sensitivity and responsiveness of the insulin receptors, and this is the type of diabetes that occurs later in life. Another clinical relevance we can talk about is insulinoma. It is tumor of beta cells. So this is when there's an overactivity of beta cells, which can lead to increased levels of insulin, leading to hypoglycemia. So if it gets lower than physiological levels, so below 60 milligrams per deciliter, it can result in loss of consciousness, and it could be as severe as leading to coma. So that is all there is for the pancreas and the endocrine functions. I hope you enjoyed the video, and thank you for watching.